Thank you very much. Thank you, Professor Shabba Basiri. I hope I don't get red cards here. I would like to thank the Mr. Staff, Dr. Saad Rashidi, and all the group, Dr. Nadeem and Dr. Professor Binol, for the great conferences that we are now seeing the growth since last time. So this is really good achievement, and we hope we continue in terms of the growth and the numbers, and because this is the gap that we always wanted to be filled, and Mr. just came on the right time. So that's very good for the practice of radiation in the region. So I hope my few slides here will be very light as we are starting our morning. So just as a disclosure, most of the data here are either verbal communication or obtained from the unpublished data by the National Cancer Institute. So thanks to Dr. Shabba Basiri for this. So the number of radiation facilities in Saudi Arabia. So how do we have, in terms of the radiation machines? The LINACs and tomotherapy, 37. So we have 35 LINACs and 2 tomotherapies in the kingdom. 4 machines of CyberKnife, 1 Gamma Knife, and 9 gynae brachy and 1 prostate brachytherapy. 6 centers where they have intraoperative radiation treatment, and 1 orthovoltage machine. This is distributed in the different centers in Saudi Arabia. So when you look at the distribution of these facilities in the geographically in Saudi Arabia, so most of them are centered around the Riyadh, Mecca province, as well as the Eastern province. And then there are so many regions in the kingdom where we do not have machines. In terms of the simulators, we have mostly CT simulators, 17. 2 centers, they have CT PET for simulation, and 1 center where they have MRI simulator. 62 radiation oncologists, 91 medical physicists, and 164 radiation therapists. Again, these are numbers from the entire radiation oncology facilities in the kingdom. So if you look at the ratio of machine per million of population, then you see that in Riyadh, this ratio is 2, which means that we have 2 machines per 1 million of population in Riyadh. This number goes down to ICU, to 0.5 in ICU, which is the lowest number that we have here. And then there are 4 or 5 regions where there's no radiation machines. Overall, this ratio is 1.15 for the entire regions in the kingdom. One of the very common or commonly used benchmarks or reports to estimate the number of machines required is what we call the ISRO Quartz. The ISRO Quartz report was published in 2005. And it was based on the European centers where they actually studied the centers and how many patients and etc. and population, etc. So, and then they came up with some kind of figures classifying these countries into high resource, medium resource, and low resource countries, and then how many LINACs are required per population. And this is the general population of the countries. If you actually plot the data from Saudi Arabia against those 3 benchmarks from Europeans, we are also not meeting the low resource country in terms of how many LINACs per million of population. So for the low resource here, 1 LINAC per 5,000 of the population. And for high resource, 1 LINAC per 180,000 of the population. So overall, we are short on these figures. And then when you look at the IAEA reports, this was updated in 2017. It's a very lengthy report. And basically, the figure that they are still using it is 400 to 600 courses of treatment per LINAC. So if you reach to this number, 400 or 600 of treatment per LINAC, then you add the other LINAC, etc. And then they had a very good analysis indicating that the utilization of radiation should theoretically be higher in the low and intermediate income countries compared to the high income countries, which is the case right now. So looking at the very common method of kind of estimating the demand, which is a 50%. So how many cancer patients you have, solid cancer patients you have, and then 50% of those patients roughly will require radiation. And I'll show you where this figure actually came from. But if you apply this rough rule on Saudi Arabia, then pulling the data from the statistics from the 2018 report of the statistics in Saudi Arabia, then we have about 20,000 total number of cases. This means that 10,000 is roughly the 50% of those patients. If you assume 10% re-radiation rate, which is what the International Atomic Agency suggesting is 10% re-radiation in the developing countries and 25 in the high income countries. So this will bring the number to 11,000. So the number of LINACs required in Saudi Arabia is 18 to 27 for the entire kingdom, for the entire population of Saudi Arabia. This is truly not correct. But this is just is outdated. So the caveat is the registry data is coming from 2018. So what is the current data which not have this? And then the conservative re-radiation rate. We're not only talking about re-radiation. There's so many other things, which is how many number of radiation per patient. We tend to treat the same patient and I see this in brain metastasis, for example, patient where I treat one lesion and then a couple of months another lesion, etc. Not to mention the SBRT for extracranial disease, etc. So, so this is what I mean by expanding of indications of radiation treatment. So benchmarking for staffing. We do have the updated report of the ISTRO group. They call it ISTRO Hero survey. And again, based on the European data. So they came up with kind of average number of required radiation staff per million of the population. So if you look at this, or I'm going to go back here, we are also not meeting this in Saudi Arabia. If you consider the entire population based on this data, the European data, and this report was from 2014, so we are short on radiation oncologists, medical physicists, and radiation therapists. The blue column is what we are having right now in terms of the numbers, and the orange one is what they propose in this paper. If you look at the optimal staffing, these are the different types of bodies where they have ballpark figures for the staffing. And then when you look at the IAEA report, they suggest 250 to 300 patients per year per RO, 300 per year per physicist, and 100 to 150 per year per radiation therapist. If you apply the current staffing, then we would probably need less. So what is the problem of all of these figures so I think the main issue here is how to estimate the demand of radiation. It's a very complex area. So many assumptions that go into estimating into the model that you use demand and supply of radiation oncology. So the first question that we have to ask is, does the 50% figure still hold true? I don't think so. The 50% of the population require radiation. And then what about the axis? So we know the axis differ between the countries and in Saudi between the regions as well. So what is if you do not give the full access to the population to the facility, then how can you estimate the demand, or how can you project the demand, etc. And then the re-radiation rate, is it 10%, 25%, more or less? So what about increasing indications of radiation with SBRT, with other things? What about the productivity of the radiation oncology? We cannot say that, oh, well, this number of patients, we need this number of staff. So you have to consider the productivity of those people. And the productivity has so many other variables that go into the model of predicting the productivity. Complexity of the plans. So all of these numbers, they came from so old days, and then the plans were 3D, if not less than this, right? So now we have much more complex plans and much more complex treatment machines, etc. So what about faster machines, FFF and other machines? This will also change actually the workflow of the patient. efficient workflow, etc. So all of these variables are not considered in the current model of that actually we use to estimate the demand of radiation oncology. So whenever we start thinking about estimating demand of radiation oncology of the first thing that we have to do, and probably the only thing that we have to do, is estimate the demand. And then you can calculate the stat, etc. And then there's no problem with this. But estimating demand is the much more complex task to do. So how do we estimate the demand? What are the existing models to estimate the demand? The first one is Delphi panel method. And despite the fancy name, it's just expert opinion. So how many VNATs we have on this and that, and that's all. The other methodology is based assessment, and they call it BEST. And this one is really a little bit more kind of, they extract the epidemiology of the patient, number of cases, and then they match it with the best, they create some scenarios, so they match it with the best evidence showing indications of radiation, and then go with that thing. The last one is benchmarking, which is a bit more complex, but not accurate as well. So most of these studies, using the models, these models, they estimate the 50% figure that we are stuck with now. And look at the references where these models were created. It's 1991, 1996, half of this of the attendees today were not probably born at that time. And then the 2005 is the most recent one. So we are so outdated on these figures. In developing countries, even this 50% of the radiation requirement is not met in the developing countries. This paper showed that it ranges from 30 to 35 or so of the patient, of all cancer patients, actually gets radiation. So even the 50% probably underestimated number is not also met in our countries. So just two couple slides before I get cognizant about how to calculate the radiation oncology demand. So I talked about radiation demand, like treatment demand. So what about the radiation oncology and staff demand? So in 2010, the ASTRO workforce, they formed workforce to estimate the demand. And the conclusion was that demand rapidly exceeding supply of radiation oncology. So the demand of radiation oncology, which means demand of radiation treatment, is actually rapidly growing. So in response to this, what they did, they opened all the doors for the residency, the number of residency slots doubled, etc. And then in 2016, the same workforce, they got together and they actually realized that the supply was rapidly exceeding demand of radiation oncology. So they said, you know what, we should take a step back or something like this. So what they did, which is the right thing to do, is they outsourced this study to people who are specializing in developing models, developing kind of statistical and mathematical models to model this very complex task. So what they did, they outsourced this task to the HMA, which is Health Management Associate. So in 2022, this company with some representative from ASTRO, they came together and they actually developed a very sophisticated model, and they found out that projecting the numbers to 2025 to 2030, there's balance actually into the supply and demand. So, and the report of this body, of this independent body, it actually showed that simply using number of radiation oncologists and number of patients requiring radiation not sufficient to estimate demand and supply of radiation oncology. And that is what all used in the past. So they came up with a solution. It's a very complex solution, but more accurate. So the supply is the number of radiation oncologists multiplied by their productivity in WRVUs, and I'll come to that. So they start talking about actually productivity per radiation oncologist. And the demand is the sum of all of those WRVUs that the patients receive. So the WRVUs is actually the work relative value unit. So this is the unit that they came up with to actually define the productivity of the radiation oncologist. So just 1.5 slide. So demand. For summary, if you want to estimate the demand and then you build everything on the demand of the patient, projecting it into the future, you have to consider what's happening to the access. In Saudi Arabia, we will probably be having more access because of the insurance now that would be applied, and also because of more private cancer centers that will operate and have radiation treatment. And then increase in the population, increase expanding of radiation oncology, radiation treatment. What happens to the oligometastasis? We'll likely be treating more oligometastasis. This was not indicated in the past. And then the high risk born, for example, high risk born patient. Now we're having more time, more evidence to consider treating these patients. So these are completely new indications, and big chunk of patients will be affected by this. An increase in innovation. Innovation, it will change the shape of the practice, like SBRT or hyperfractionation, etc. Some supply considerations, we talked about this. So the future is likely the number of radiation facilities will increase, regardless of what model you're going to use actually in Saudi Arabia. So probably, I'm just guessing, and upon some discussion with colleagues, over the next 5 or 10 years, it will be at least double. And then we will have soon, hopefully, the proton therapy as well. And some centers, they are trying to get MRI LINA. So the conclusion that we need to increase the capacity. The demand is a very important step, and we have to be as accurate as possible with estimating the demand, because all our calculations based on this. And then due to less cancer incidences in Saudi Arabia and some other different variables, I don't think it's right to just bring the external benchmarks and use it on our own population. Thank you very much.